All right. Hello, everybody. Welcome. Happy Friday. We are here with the wonderful Dr. Bahar Esmaili. I appreciate everybody joining us. Dr. Bahar, before we start, I would like you to introduce yourself to everybody. And thank you for being here. Go ahead.
Thank you, Renata, for that wonderful intro. My name is Dr. Esmaili. I'm a dentist, practicing dentist in Boulder, Colorado. I've been a dentist for 12 years, and for about 3 years, I've made it my mission to switch gear from tooth dentistry to whole body dentistry. Because I started treating a lot of patients with temporomandible joint disorders, sleep breathing disorders, which is all kind of the same area. And once I start seeing the total body suffering as a result of those symptoms, I just could not take a step back. So I'm a huge part of Vivos Therapeutics. I'm actually part of their research and development. Also, I'm still in practice doing clinical airway dentistry and TMG treatments. But one of my biggest passions is bringing what I learned, both from research, reviewing the literature and clinical practice, and from collaborating with other doctors I work with, bring it here, share it. Because there's nothing better than spreading the knowledge, because everyone who's attending, I want to make it worth your while so that you can take something valuable, take it back home and apply it. If you don't know the answers, so hopefully you can find out at least where to find the answers. So I'm going to just give a quick start with the background of TMD. Tonight, we're just going to be touching up on some of the key points, some of the, I would say, bite-sized pieces of information, not deep diving into it, but if you have any questions, I'd be more than happy to elaborate. And if there's other attendees that can help out, I would love that as well. TMD really has a special place in my world, because really, in my belief, in my clinical practice, it's where the body and the head meet. Let me explain. This is not a joint. This is a very complex area, and it's one of those things that we only have been dealing with the symptoms of it forever. And for the most part, dentists just did not want to treat it because it is not simple. It is something that body adapts and patients adapt. And unless we're digging into the deep cause and the root cause of it, we will never know that really some of those is not contributed from the teeth, but from the rest of the body. This is why it has been getting a bad rap so far. But I'm hoping that we're going to start breaking ground, and by treating patient as a wholesome, we understand what contributes to the disorder. So for now, we're going to call it an umbrella. I think it's a whole body disorder, because our jaws developed from early on when the kid is born. All we had babies, they have a very small lower jaw. That lower jaw is not quite done growing, and neither is the rest of the face, but that lower jaw will develop and do what it does in all dimensions to support functions. So that's the first thing we have to just agree. Some of the facts we're going to touch up on, those are the things that we can bank on and take it home. The lower jaw will develop its function. Before and during the puberty, the airway and breathing and swallowing pattern and craniofacial growth has a tremendous effect on the jaw development. And those are the things that are right now where we're starting to see the tsunami effect that it has on younger and younger patients coming out with the symptoms. Popping jaw joints, noses, headaches from the muscles that are trying to stabilize it, neck postures because of it, all of it being symptomatology. So I'm going to start my presentation with this. This is the human kinetic chain. As a movement specialist, I have a background in corrective exercises specialty in kinesiology. I was very familiar with this until I started seeing things as a dentist from upstairs to down. That's when this picture made sense to me. So let me break it down to you guys. Think of your hips as a tabletop, okay? And your legs are the legs of that tabletop. Everything above that tabletop needs to be stabilized, including this entire spine and the 12-pound medicine ball, the head. So if you think of the tabletop, the hip as a triangle, the spine as another, and the rib cage, and then the head as a third, anything that is out of balance on the top or the bottom can affect the other way around. So if one leg is shorter than the other, muscles of the leg are out of balance, foot positionings are wrong, for whatever reason, walking is dysfunctional, you could see the hip position changes and everything above that. Same thing with the other way around. If the head position is wrong, that triangle is going to affect the bottom ones to stabilize it. So we call that ascending and descending. So posture really bridges the gap between the structure, function, and neurology. When I look at somebody's posture and how they're holding their head, how their hip is shifted, how the rib cage is shifted, everything else around it, What I see is how deviated they are from being straight. If I put a straw from or string from the tip of the head all the ears to the toe, it should be a straight line to be completely balanced. And any deviation from that is a dysfunction, is a compensation for a function that is not quite working. We're going to get to a little bit of that later. So now that we have that understanding, let's call TMD a better term, craniocervical mandibular disorder. Really, it's all of it. And it all starts from the top, take it down to the bottom. So it is a misalignment and how the lower jaw or the mandible is related to the cranium, to the base of the skull, and more importantly, to the cervical number 2. In a couple of slides coming up, I have a good demonstration of actually how the mandible and the neck are connected. And this is the belief you're going to walk away with. Body owns the mandible. Mandible tells the body where to go. It is not an extension of the skull. It is hanging from the skull with a bunch of ligaments. It's one of the only bones in the entire craniofacials that is not attached to any other bone with sutures, but a whole bunch of ligaments and muscles. So you could bet the best position of it, which will affect the temporomandible joint and the lower teeth and everything else, including the tongue, has to do with its function. So where the mandible is structurally and functionally, if it's compromised, you could see the whole entire body is going to be under stress because, again, mandible is a messenger of the body, as I call it. It's owned by the neck and the body. Maxilla belongs to the skull. So I want to simplify things. I love simplicity, and I want you to walk away with points that you can take away and just remembering. What are my priorities? What are the things to remember? There are 3 main rules of survival functions. Survival needs of the body that they need to be met. If they're not, we're going to see compensations. First is breathing. The kid is born, got to take a breath, or that baby's not going to make it. Second is balance of the eyes with the horizon. If your breathing is not functional or is not happening in the where the head is in the right place, head has to be adjusted for breathing function. Now eyes need to adjust to that new position. Eyes need to stay level with the horizon. And the third is brain. I kept the theme with the bees, but brain is really the head. The 12-pound medicine ball now is at the mercy of eyes level, breathing happen. Now I want to make sure the head doesn't fall forward. So if breathing and balance of the eyes are causing compensation to the position of the head, now the entire kinetic chain is going to be under stress trying to accommodate that. So let's go over the functions of the jaw. Again, we're just going to cover some facts here. The functions of the jaw during development, the primary function of the jaw is to support our breathing mechanism. That's basically what it is. So all of these functions are going to allow the growth of the mandible and where it's positioned. Primary one is breathing. Second is sucking and swallowing of the milk, extracting the milk out of the breast, and being able to swallow correctly. Third is chewing, and then last is third is chewing, and then last is speaking. So in the order that we see here, that those things have to happen. So if the first one's compromised, I don't imagine the last 3 are going to happen in the correct function either. So what I call malocclusion, where I used to see as a dentist as a malocclusion, really now I see it as a body misalignment. When I see teeth crooked, broken, fractured, recessions, all damages, what I do see, or torsion, if the lower teeth are just torsioned in, or crossbites, and the upper teeth are flaring out, what I do see is not the teeth anymore. And I'm hoping by those dental professionals that are either watching this live or watching it in the future, they can see a glimpse of this. Teeth position are speaking volume on body misalignment because they're trying to accommodate to a compensation pattern. So a mandibular position is directly affected by all the functions that I just kind of mentioned. So looking at this picture as a deep level, again, I knew the movement specialists can relate to this very well. Head over the spine, as the title of this presentation says, head over the spine is where the health happens. Everything is happening. Great. Nasal breathing is established. Mandible has a good position. Occiput to the atlas has a good distance. So all the muscles are relaxed. They don't have to hold the head, the last brain, in a compromised position. Everything is happy. What happens if the head moves forward? We're going to call it for functional problems. Then the mandible needs to also be supported in that position. Now, taking a look here at all the suprahyoid, infrahyoid muscles that are trying to pull this mandible and support it in the wrong position is going to be affected. So, applying that rule of 3B to a nasal breather versus a mouth breather. Remember, breathing is the most important function. If breathing through the nose is not happening, tongue posture to the roof of the mouth is not supported, diaphragm is not activating and expanding because the pelvic floor is misaligned, that's what we see, the picture on the right. that person needs to be able to use their mouth to breathe, and their head is going to get forward. So look at all of the structures that are not be under stress: orthopedics, muscles, fascia, and now the nervous system that governs it all. So this is the simplest picture I can come up with that demonstrate sympathetic and a parasympathetic tone in a very short diagram. So right here on the left side is someone that doesn't have to compensate. The nervous system just doesn't have to work double as hard, double shift to keep things in the right place. Mandible is supported beautifully in a place that can support the airway, swallowing happening naturally, normal cervical or spine in the curvature in the spine. Position of the occiput over the atlas is pretty good. Again, this is a better scientific picture here. This is the mouth breather. This is a living picture of a sympathetic upregulation to accommodate those dysfunctions we counted. Mandible has to be propped forward, down. Tongue tree has to get a lower posture. The eyes need to stay level with the horizon because now everything's under stress to ensure breathing, balance, and brain are happening, right? That's what we see on the right side. Hyoid bone is positioned lower in front. Again, the curvature in the spine is not great. The support of this head now is going to put a lot of stress, not only on the upper cervical, but also on the rest of the kinetic chain. The shoulder girdle has to be winked forward to keep the head from falling forward, and the arms and the pelvis rotations, just about everything down below. So the communication of we know that there is a way that mandible communicates all that to the brain. We know that the mechanoreceptors and the periodontal ligaments are pretty great receptors that with every tooth contact, enamel crest is actually crusted in nerve endings. They're not dead tissues, as we've believed for the longest time. Enamel, especially where it's the thickest, when it comes in contact with each other, the lower teeth and the upper teeth come in contact with each other, that proprioception is communicated through all of those nerve endings attached to the teeth and the crestal, the periodontal ligaments to tell the brain, and that message goes directly to the mesencephalic. It does not stop at the brain step. Basically goes straight to the brain to tell exactly what you're encountering as far as the food, where the mandible is in terms of its contact, just to make sure all the survivals are happening correctly. It is by design, but also at the same time, it is something to be taken into consideration when we're dealing with boxers and patients that have breathing disorders, because now they have a magnification of that same mechanism that was designed for them to function better. Now they're not. The way I can break this down into a simple term is if you wake up and want to go to the bathroom in your own room, in your bedroom, and it's night at night, you know exactly where to go. You're skipping the furnitures and finding your way without hitting much. Or if you come in contact with something, you know what it is. You skip it. That's proprioception directed through the periodontal ligaments. But if the mandible is not positioned correctly, then the teeth kind of hit each other. Instead of having contact-oriented proprioception, they're going to have contact-oriented movement. So basically, the teeth rub each other the wrong way, wrong teeth, wrong place, and it's almost like getting up and go to the bathroom in a hotel room every night. You don't know what's where, and everything you hit, you're like, okay, I'm going to avoid that. I'm going to avoid that. I'm going to avoid this. Those are teeth that look worn, dentition that are flattened out, and there's no rhyme or reason because body, the mandible, and everything is out of its position. But the better question is asking why. So here's again, we're just going over some facts, and I'm actually citing all the literature that I cited for this presentation right on the below. And if you guys want the original research, I'll be more than happy to send to Renata, make it available. So the theory of Gauze, if I could say correctly, it's talking about the axis of the mandible rotation being straight through the C2. Because we're thinking of the temporomandible joint as the axis of opening. But if we're looking closely, and I have a demonstration in the next slide, mandibular closure and opening is directly through the odontoid process of C2. So when the mandible moves down, it causes pulling on the muscles of the C2, cervical spine number 2. And when the mandible is closing, then it's causing the tightness. So the movement of the mandible is affecting the muscles around the C1 and C2. So if you think about it, if you have a vertical dimension that is diminished, if a mandibular position is incorrect or compromised, that compromise is directly affecting the neck position as well. So a TMJ problem can affect the position of the cervical vertebra. This is an actual picture I took from that literature that I just cited, showing the occlusal plane and how it's related to the cervical spine. So this is where our collaboration begins, guys. This is where the dentist, chiropractors, physical therapists need to come together, because every dimension that dentist changes in the mouth, everything we put in the mouth, every dimension we're changing things is going to directly affect the neck. So we can call the most important vertebra in the entire spine being C2. And on top of that, the upper cervical vertebrae are designed to communicate and rotate in the same direction as the lumbar. So if you have a C2 problem, you also have an L4 problem. If you have a problem with the position of the head being in a forward in relation to the spine, now you're going to have a lumbar problem too, because C2 will affect L4. I don't remember exactly quite the order, but C1, C2, and C3, they rotate in the same directions and they get the same compensation as L4, L3, L4, and 5. So distortions that will be starting in the mandible. This is the cascade of events. This is why you guys are here. I'm excited to tell you. When we see pain in the jaw, when we see dysfunction in the teeth, this is also a body problem, because distortion, this is right here explaining TMJ distortion causing pain and nociceptions, reflection to the upper cervical problems, atlas and axis misalignment, subluxation, and the cascade begins because they go back and forth. So now we have a posture that's affected by what was started in the mouth, or the other way around. So one of my favorite ways to put scientific things into simple terms is resorting to my kids. Renata can relate to this one. My daughter wanted to put this puzzle together, and she didn't know how to stop. Just like when we see a TMD disorder, we just give it a title TMD and leave it alone. That's a TMD dysfunction for you right there. All the symptomatology we see. If we were to do this, this is how I would start it. Corners. Find the corners. Find the flat ends. Find the same colors and patterns. Find your outliers. Find pieces that have details that are not relevant to each other, but very important in the long term. And then finding pieces that you might think they fit where they do, but the pattern don't quite support it. So if you're biased in thinking that that information was valuable, but I can't really find a proof, maybe that information is valuable to the clinician down the road that needs to treat that patient. That's where the collaboration comes in, seeing the big picture together. That's it. That's the human puzzle for you. The neck, the jaw, skull, sphenoid bone, a rotation, activation of the diaphragm, pelvic position, cervical, all of it right here is the human puzzle that we're trying to put together. I'm holding that blue piece, right? I'm a dentist. This blue piece and that yellow piece, or maybe some of that yellow piece. But then I know that there's so many different parts that so many other providers need to provide that are fitting together. And unless there is collaborations, we can't take care of them. This is my melody. This is my why. And for those of you who have heard my story, I apologize. I want to very quickly zip through this and tell you guys about it. Melody had sleep disordered breathing when she was 3 years old. And that's when I didn't know anything about the TMJ, the airway, and everything that I do now. So when she was 3 and loud snoring, disturbed sleep, ADHD symptoms, and all that, we had her seen by ENT, which suggested just a Flonase. Not excited about doing a sleep test until she was 5 years old and had full-blown ADHD to a point where the school was concerned to put her on medications. And still not sleeping well, never wake up rested. This kid never woke up feeling like I'm ready to take on the world, just like a normal kid would. When she was 7, this was 7 years old before I started treating her myself. Crossbite, grinded her teeth down to smallest knobs, and that's a posture. And I always was concerned as a movement specialist. I knew that she has a lumbar extension, that hip was flared forward, shoulders being rounded forward, and she always, her foot was pronated or just kind of flattened towards inside. And I didn't know what it was. How is that related? If I only knew then, this was all started from her breathing. At age 5, her apnea was diagnosed by a PSG lab, and she had an apnea of 10. And the tonsillectomy was the only option. That was done. Never helped. She still didn't get through the night. She was still a mouth breather. She still had nasal congestions and lack of sinus drainage until she was 7 years old. And that's what we see. She's done getting teeth. Crowding is already happening. Crossbite is not resolving. Grinding is continuing. She's vertically growing. Excess maxillary pole. Just name it. Every dysfunction that you would imagine I would have been treating so far, my daughter had it. And that's her CT, age 7. So she's already getting septum deviation because her arch is narrow. There's no tongue pressure. She's a mouth breather, 100%. Sinuses are not growing, and they're not draining. So she's headed that way for the nasal septum growth to go crooked. And then drainage of the passage of sinus is all depending on that. And that's her palate. High vaulted, no tongue, as you see, the tongue is laying low. And, oops, sorry. I'm trying to get this in the middle so everyone can see. I don't know why. I'm going to probably exit out of this so that everyone can see the picture. I'll go back. This is Melody after 6 months of treatment with me. This was my biggest concern. Her jaw is being tilted one side because of that crossbite and the grinding. And I knew her face was getting distorted from early on. And since the growth of the mandible, again, from the first bite, it's all happening to support all the functions which she was compromising on. And her body was also supported the same way. The effect was in her face. I could see it. 6 months later, her chin is in the middle. The jaws are growing in the right direction. Her vertical growth is resolved. She's been in mind functional therapy. She's been in a guide series appliance. She's not snoring anymore, getting through the night, and I have a brand new child. And that's the epiphany, that we don't see what we don't know. And I didn't know what I didn't know, but I'm hoping if I can just get one practitioner here, one other practitioner, doesn't matter what credentials you have after you're into realizing and to seeing what I see in the mouth and what you see in the body are the same. And that's right here is that picture for you. So glad to report, we're still picking up all the behavioral issues that was done when she was in intermittent hypoxia. Again, AHI of 10 during growth and development. You would imagine there's some, brain wiring that probably was missed. And yes, there's going to be behavioral problems, but at the end of the day, it's getting this kid to breathe that really did it all. And now her growth is supported. Her posture is supported. I mean, looking at her posture and shoulder canting resolved. Those clavicles are nice and parallel. Her chest is back. She's not compromising anymore. Now, if nothing was done for Melody, this is what would happen. This is Patty, 72 years old, and nothing was done. And she lost all of those opportunities to have a better, different scenario, different outcome, and that didn't happen. And she's seen as many practitioners as there is credentials to assign to, and still not treated well. And now more damage done to her temporomandible joint. We're going to get to those to see later. Cervical spine, she's still in pain. The fluids is not getting to the brain. Headaches, just name it. And these are the list of her symptoms. You see the cantings, and I see the bite. The chiropractors see the neck, the subluxations, and the misalignment of the cervical spines. You might see, if you're a physical therapist, you might see the posture. At the end of the day, it's all together. This is a person living in a sympathetic overactivity, a nervous system that realizes things aren't going to get better. I'm just going to keep that sympathetic tone on all the time so she can continue functioning. Does that look familiar? Nasal septum deviation, still not breathing, sinus pluggage, and crowding in the teeth, and compromising the neck posture, trying to breathe. And Patty actually did have moderate sleep apnea as well. And that's her temporomandible joint. Complete loss of joint space, subcondylar cyst. We have definite osteophyte forming, which is bony changes in one side is worse than the other. Loss of joint space again, cortications of the condyles are gone, and still rubbing bone to bone. So now we know that her neck effect and its replica of what we see in the temporomandible joint. Dr. Droder, a good mentor of mine, gave me this slide years back, and to this day, every presentation, I would love to put it out there, beautifully summarized. And he's a great clinician. We see signs and symptoms here. Renata can probably nodding right now. These are signs. These are smokes. Melody had them. Patty had them at some point. We don't treat them, we're going to get here. We don't take it seriously, now we're going to see irreversible damages. When we're seeing AHI of 1 to 4 on even an adult, I don't call that normal. I call that a dysfunction. That's body's way of attempting to fix things. If you have an RDI of 15, a respiratory disturbance of 15, and an AHI of 2, that doesn't mean the person doesn't have a problem. That means they're fixing it with everything else, trying to prevent a problem from coming up to hypoxia. So tongue tightness, bottle feeding, dysfunctional swallow, allergens, nasal obstructions, enlarged tonsils, adenoids, mandibular deficiencies, all of those are signs of smaller airway. Not treated, what's going to happen? It's an asymmetrical phase, a temporomandible joint that is going to be shifted to one side, and all the functions that needs to be supported are now happening in dysfunction, and now leading to destructions of the tissues, the bone, the muscles, and symptomatology after symptomatology. So Dr. Karen Davison, a good friend of mine, she is the vice president of the GM, makers of rhino manometer. which is a device, a beautiful device made for measuring the nasal resistance, which is the most important function of the body. And she put this diagram together. It's kind of scary and took me a while to get through it, but really it's just to discern. Is it an obstruction in the nose causing the problem or inflammation? Is it something that can be cleared? And if it can't, is it something that needs to be corrected with what specialty? What other imagings do we need to find out? Who needs to go and get that patient to treatment first? This is a good first step in triaging the patients and directing them between all these professionals that are named here. I believe there's room for an orthodontist as well, or some dentist treating airway dysfunctions. But basically bringing it all together. Renata, there's a mind functional therapist here too. ENTs, sleep physicians. It's a concert, guys. And to direct it all together, unfortunately, we don't have a director. In our medical system, when a patient comes with a symptom, only sees one of us. And if you're all looking at, if we all go through the same pattern and checking for the function, the breathing, we always figure out that if we find the source of the problem, we can easily prevent the symptoms from progressing and address them and never have them come back. That's kind of why we're here in a nutshell. So ending the presentation tonight, and as I promised, I kept it under 30 minutes, is my favorite book of 2020. And this is going to be my favorite book for a very long time, From Breath by James Nestor. Gentleman was not a doctor and wrote a book that got the attention of millions to pay attention to nasal breathing and how breathing is important. What are the detriments of the body's lack of nasal breathing? He said it, no matter what you eat, how you exercise, how skinny, young, wise you are, none of it matters if you're not breathing properly. And the proper way to breathe is through the nose. So I know we start with temporomandible joint, and I know we're talking about posture, but to have it all, I tell you, for me, if I take it from the top, I would always go after nasal function after breathing and clearing how the patient is functioning. And when we take it in that order, it almost becomes a triaging that is on its feeding itself when we know how many of these providers can come and help each other. And we can go to the nitty gritty of every single one of those slides. And there's so many amazing physical therapists out there that can talk about body's flexibility and hip positioning, that all is going to be an ascending problem going upstairs. Which one was it first? And being able to get those answers. But for now, I think I'm done with my presentation, you guys. I don't want to be boring this one-way talking, bring in questions. Let's make it interactive.
Yes, this has been wonderful, Dr. Bahar. You always drop the mic every time. Let me turn this on. Let's here. How can we get our view back right here? I do have some questions over here from our audience.
Sure.
Let's see. Oh my gosh, why am I looking like that?
We love you either way, Renata.
Oh my gosh, I should have looked at my hair before. Great. Okay, perfect. We're back. Well, thank you so much for this wonderful presentation. My goodness, you are just fantastic. And I do want to tell everybody that's watching, this is just a little nugget of what we are going to be doing with Airway Circle. Next week, we're going to have a pre-launch for our membership. Our membership is going to be $25 a month, less than $1 a day. And we're going to have courses like this on our platform for members. We're going to have research that you can download. We're going to have amazing discounts from products that you can't get those types of discounts anywhere. There's a lot that we're putting together in there for you guys. And during our pre-launch, if you guys go ahead and get your membership, everybody's going to get a free Airway Circle cup. We just got some new ones out. There we are. So super excited about this stuff. You guys stay tuned. Our speakers for next week are also wonderful. You guys are going to be very surprised. And right now, let's see questions, guys. You guys are. I have my phone right here because we have so many questions on Facebook.
Nice.
So the first one is by Emily. How can we help kids correct forward head position?
Grand questions. When I see a child, and I do see them frequently, especially in my area clinics, with a headward posture, the first thing that I want to know is, first of all, does this kid have any, was it breastfed baby? Did they have any trouble breastfeeding, swallowing, speech problems and whatnot? And also checking any sleep problems and breathing problems, because if a child in fact does have a head forward posture, the first thing that needs to be corrected is the nasal function. Melody, Melody is a prime example of that. You just saw how actually correcting her tongue posture, working with a myofunctional therapist, and getting her taping her mouth completely rerouted her breathing. The snoring obviously stopped after tonsillectomy, but the actual nasal breathing that was established was one thing that got her to correct herself. Because really, a head forward posture, there's so many different faces to that. A child that's 3 years old and they have a lumbar extension and forward head posture, that is not ergonomic. I mean, we know breastfeeding children that have torticollis and they have tongue tightness. And again, those are terms I borrow from my movement specialist. I'm not an expert in explaining it, but when they're using sternocleidomastoid to stabilizing their jaw because they have a dysfunctional swallow, that's going to be affecting everything below. So that's their breathing muscle, right? But why are they using that instead of if the tongue is dysfunctional, if the nose is blocked? So I would say, depending on the age of the child, if they're walking of 2, 3 years old, I would definitely focus on breathing, making sure that they're not obstructed. The tongue is not a problem, nose is not the problem, and working with an allergenist, an ENT. Check the nose. I would say until the nose is checked, forward head posture should not be considered as any other treatment until we check the breathing, because we know posture is sensitive to nasal function for sure. I hope I answered the question, but if you clear the nose, clear the breathing, working with my functional therapist, have a physical therapist on your side too, because I know some of these kids need to be rewired for their posture. They need to work with those individuals. The goal is not to have them revert back, to make their posture sustain itself. Melody had to have a couple sessions, not a whole lot, to correct her fascial, release her fascial, because she was really molded in that position after we corrected the breathing, not before.
That's fantastic. Yes, that you did answer the question perfectly. And that's actually similar to the question that I had written down. Well, also I had, will bed posture alone kick in your sympathetic system? You talked about that a lot, and I thought it was super interesting because, I've been breathing correctly, I feel like, with Takeo and just trying to breathe better, slower for 5 years now. And recently I went to the chiropractor and they did this little test to see if you're more sympathetic or more parasympathetic. And I was still more sympathetic. And I'm like, I'm going to, and I was thinking to myself, I'm going to beat this test. Like, I know how I'm breathing so quietly. And no, but yes, I do have forward head posture and forward shoulders. And it's super difficult for me to breathe unless I am in that position.
Mm-hmm. Actually, you mentioned a good point, because my chiropractor, Dr. Sopri, she's excellent, and she works with a lot of my patients. And just recently, her and I worked and triaged the patient. Again, that's the point of this club, right? Sharing our successes and sharing our experiences, and also saying who are the outliers. So this patient has severe narrow maxilla. She's tongue-tied, had the entire body checked. She's into all holistic health, had her cortisol levels checked, blood work, genetic testing, name it, right? And nobody ever gave her a sleep test, right? Mm-hmm. So she's been seeing chiropractors. So what we did differently, we started with a myofunctional therapist, and the myofunctional therapist started training the tongue. And we got her just a mandibular device to bring her forward at night, because she was moderately apneic. And Dr. Sopri started adjusting. So what happened is, after a couple of months, first she started dreaming. The adjustment, that sympathetic tone that you're talking about, I call it the Gulf, right? Red, then we have the yellow, and then the box, right? Yes. She was dark red, now she's in yellow. You're right, she's still in the sympathetic, but she's in yellow, almost in the degree. Why? Because we took the compensations away. Our sympathetic nervous system was designed to keep us safe. And if there's anything, a perceived threat to our life and our survival, sympathetic kicks in, right? And when it kicks in, it does what it does to prevent you from dying. I have a very ironic thing to say about sympathetic nervous system. Our primitive brain, through our ANS, or autonomic, through our sympathetic tone, was designed to keep us safe. It will kill us to keep us safe, gradually.
Wow.
That's exactly what it does. I mean, thinking about how much cortisol we're producing when we're not breathing at night, right? All this epinephrine, all this children walking around with this forward head posture and dark circles around their eyes and misbehavior, I always look at them, I'm like, wow, that kid is a living, walking example of a sympathetic overdrive that's drip, 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 never off, right? Can we say that by fixing the function we can reduce that sympathetic tone? But you have to believe at some point things have to be rewired, because a child that has had hypoxia and they've always lived all these sympathetic tones, they still are running those hormones, right? They have to have some behavioral changes happen to them. So can we reduce it? We can address it. And that's why we all come together. There's some areas of medicine, actually, cognitive behavior. Help me with the term here, Renata. There is an actual specialist for this. It's a big, long term, it's like four words in one specialty. It's a cognitive and a behavior. It's basically saying that someone living with the stress and pain and chronic situations for long enough, now we need to get the brain to get the memo to stop that progression of sympathetic tone. So there's that too. Again, we can dig into the literature and see what's there, or perhaps research it ourselves. But autonomic nervous system definitely is what's governing everything. Everything that I just demonstrated in every slide, that's autonomic nervous system talking.
Wow. Very, very good. Emily also asked, can strabismus or the eye condition be related to incorrect posture? So crossed eyes?
It very well can. As a matter of fact, we know we know that I've actually, in one of the clubhouses that I'm a member of, we're talking about this muscle that nobody talks about called sphenomandibulosus. It's almost like running the same direction as the medial pterygoid, but it's attached to the orbital. So I thought the clenchers are going to have eyesight problem because it can pull. Who knew? Definitely, there's a great deal of connection. And the other thing to be touched up on, what's governing the eyesights and movements and the sensory functions. Trigeminal nerve. Think about what's happening to the trigeminal nerve, compensating for all of them. Remember, the first thing I mentioned was mandible is being held by the body as a messenger. It's literally an extension of the body, not the skull. So mandible in its position is definitively determined by the trigeminal nerve. So trigeminal nerve also communicates with other structures. So definitely we've seen a lot. And Dr. Martha Cortez is a great resource to answer that question. We should have her on board talking about eyesight. And she has great exercises that I would love to hear about. Dr. Martha Cortez is an amazing resource. She has a great deal of background in osteopathy, and she's great.
So she's listening right now and she's commenting on here.
I love you, Dr. Cortez.
Anne asks, is there a connection to scoliosis that begins at the C-spine?
You know, as a dentist, I try to not ever commingle and give ideas that chiropractors should, but scoliosis is literally a definition of when the vertebrae are subluxated, right out of its place. Let me go back to Renata, I'm going to share screen again. I'm going to go ahead. Yeah, here we go. I'm going to share that slide right here. Okay, so remember that simplicity. Here's your tabletop. If that tabletop is cattywampus, right? So everything on top of it, think about if this was dynamic and the hip, its position of the hip was off. And by the way, think of your diaphragm and your hip, pelvic floor, and then everything in between as like a bubble, right? Your spine, if we're talking about scoliosis, is right in between. To stabilize the spine, the contraction of the pelvic floor muscle governed by the pelvis and the diaphragm, which is right here in the rib cage, should be simultaneous. So if one is off, it's going to be lack of support for the spine. So the functionality of the breathing and walking and the whole mechanism together, Dr. Ron Haruska from Postural Restoration Institute has great, tremendous resources. Courses I actually have attended, and it gets your head spinning if you really want to dig into it, explaining how breathing and walking together causes that dysfunction. The scoliosis is literally body's way of saying, this is how I can prevent this 12-pound medicine ball, which now feels about 60 pounds, from falling forward. Functional for a reason, because now the muscles that are tensed up to support this, if the function is corrected and muscles are released, again, I'm not going to talk as a chiropractor, but I'm talking as a clinician. Think about it this way. If I have the same condition in a temporomandible joint, if things are not out of its place, if the pathology hasn't advanced far too much to have the disc out of its place, now we're cartilage to cartilage and bone to bone, I can correct myalgia, or even for that matter, or myofascial pain or stress in the muscles if I can correct functional position of orthopedics. That's great. We don't have to have an scoliosis or a potential problem here that leads to a joint problem. The problem with compensations that do last long and causing orthopedic damages is they're not going to correct themselves. So that would be some question for chiropractors. But I absolutely 100% agree that functional scoliosis could be related to as well. And I see it all the time. I have corrected so many people, not correct, I'm going to take that back. I have helped people with the lumbar spine pain. They had a breathing dysfunction. Can I permanently make it go away? Not with the credentials that I have after my name, but yes, we can help them breathe better. So therefore, the chiropractor can make that connection. So that's where the collaboration. That's pretty much the purpose of a meeting like this, to bring up those questions. So thank you, whoever asked that question. Thank you so much for that question.
And wonderful, Anne. She always has the best questions. Dr. Martha Cortez said, so with Foster need also work with vision therapy in addition to fascial. She always talks about visual therapy to aid in all of these things. So it is wonderful.
This is no that Renato, I actually wrote this 3Bs. Honestly, talking to tremendous mentors like Dr. Cortez led me to this. And every time I hear everything, I'm like, yep, go back here. Breathing, balance, brain. Brain. Every single time.
It is so important.
Yep.
Guys, do you guys have any more questions? I know we're a little bit delayed on Facebook, but I see Beth is live. Naomi, thank you guys for being here. It was a good room tonight.
Thank you guys for coming spending an hour Friday with me. This was just a glimpse of what is to come. We're excited to actually have you all on board and sharing future cases of retrieving. I have so many patients in care right now with so many specialists. I cannot wait to bring them and collaborate and asking you guys. It's just by sharing and practice, right? We call the practice for a reason. Sharing the knowledge is where we're going to learn and perfect our ways. So
definitely. So guys, if you are not part of our newsletter yet, you can go on our website and just sign up with your email. We're not going to send many newsletters, but we are going to try to keep you guys up to date with what's going on at Airway Circle. So you don't miss any of our courses. We're going to have courses once a month. We're going to have case study presentations. They're going to be able to meet all for members. So please keep in touch. There's a lot more coming that I'm not going to say right now. But if you'd like to know more, please message any of us. Dr. Bahar Esmaili is on our board. We have wonderful people behind us who are helping this dream. And yeah, thanks for the hearts. We're getting a lot of hearts. We are from Dr. Martha. Thank you. The vision, because Airway Circle, we're not only here. I mean, we're giving. I was gonna say we're not only here to give, but we're going to give. We are giving all of these courses and classes and meetings for free because we want to raise awareness for myofunctional issues and airway issues. There's so many more people out there that don't know this information that we can help. But also 20% of everything that Airway Circle brings in, we are going to donate. We are going to be helping patients that cannot afford either therapy or frenectomy or whatever it is. We're going to have projects that our members are going to be able to vote on to choose where this money is going. So we do have a big purpose over here, and we appreciate everybody who supports that purpose and who's been behind us for the past, 6 months, 7 months now? I can't really remember how long it's been, but definitely we're super excited for everything that's to come. So do not miss our Facebook Live for next Friday. We're going to release the speaker on Monday. There are actually 2 speakers. Very, very excited for all you guys to be part of this. And thank you. Thanks for everybody who has been with us on our clubhouses, on our Facebook Lives, for everybody who shares this information and follows our speakers. I mean, we have speakers that have gotten book deals after being on Airway Circle. We have speakers that have gotten invited to be on podcasts and you name it, and other conventions and places to speak. So we're super excited. We're here to support everybody. If you're anybody in the airway industry, if you're a professional who wants to be heard, contact us. We'd love to feature you. But I'm going to stop talking right now because it is Friday night and I am so excited. This week was great, super busy, but wonderful. And we closed it. In Brazil, we say with a golden key, which was with your presentation right now. Absolutely wonderful. You kill it every time. So thank you,
Thanks,
thank you, thank
Renata,
you
for
so
your
much.
perpetual support. I really appreciate you guys.
Of course. Everybody have a wonderful night. Thank y'all for being here. And I'll see y'all next week. Thank you, Dr. Bahar.
Thank you, Renata. Good night, everybody.
Good night.